Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You know the feeling. It is 2 a.m, you're on call, and a patient rolls into the emergency department presenting with an acute abdomen.
The absolute classic presentation.
Right. You've got severe localized pain, rigidity, guarding. Maybe you even have some rebound tenderness.
Which immediately sets off the alarm bells.
Exactly. The clinical picture seems completely straightforward. I mean, your mind immediately jumps to a perforated viscus, an ischemic bowel, or, a strangulated hernia.
So you're already mentally prepping the OR.
Oh, absolutely. You're anticipating the laparotomy. But what you might actually be looking at is, well, a master of disguise.
Yeah.
It's a rectus sheath haematoma, or RSH, and if you rush that patient to the operating room based on the physical exam alone, you are walking into a massive, potentially lethal trap.
It really is the ultimate clinical chameleon. I mean, the localized inflammation from the bleeding, it mimics peritoneal signs so perfectly that it routinely baits the clinical teams down the wrong pathway.
Just pulls them right in.
Oh, totally. The entire presentation just screams for a scalpel.
Which is exactly why our mission for this deep dive is to break down the stepwise clinical management of RSH. We are pulling from the latest clinical literature to give you a definitive, strategic pathway on when to hold the scalpel and when you are absolutely forced to cut.
A crucial distinction.
Right. So we are going to be looking at everything from optimizing non-operative physiology to interventional radiology, all the way down to that last resort salvage surgery.
But before we get too deep into the clinical weeds here, I do need to make a mandatory stop and just state that the content of this deep dive is strictly for reference and educational purposes only.
Important caveat.
Yeah. I mean, clinical medicine is highly nuanced, right? So you must always follow your local guidelines and institutional protocols in your own clinical practice.
Absolutely. So with that established, let's talk about unmasking this chameleon. The primary trap with RSH is that the physical exam is just straight up lying to you.
It is a complete liar.
Yeah. And without the right imaging, it is incredibly easy to authorize a dangerous, totally unnecessary exploratory laparotomy. So, anatomically speaking, what is actually generating this massive inflammatory response?
Well, we're essentially looking at a rupture of the epigastric vessels, or in some cases, a direct tear of the rectus muscle fibers themselves, which leads to bleeding that's contained within the fascial sheath.
Okay, so a tear or a rupture.
Right. And what routinely catches people off guard is how seemingly benign the mechanism of injury can be.
Really? Like what kind of mechanism?
Well, we're frequently dealing with patients who simply had a severe bout of coughing.
Wow. Just coughing.
Yeah, exactly. Maybe they have a COPD exacerbation or asthma, or maybe they just strained too hard. That mechanical shearing force is enough to snap the vessel.
That's wild, just a cough.
I know, right? Now, it can also follow blunt trauma or, subcutaneous abdominal injections. But heavily anticoagulated patients are, by far, your highest risk demographic.
Right, the anticoagulation makes everything worse. And the anatomy of the bleed is really what dictates the severity here, right? Specifically, regarding the arcuate line, that anatomical landmark completely changes the trajectory of the hemorrhage.
Oh, it changes everything. So above the arcuate line, the rectus muscle is fully enclosed by both the anterior and posterior fascial sheaths.
So it's boxed in.
Exactly. If an upper epigastric vessel bleeds in that area, the hematoma is confined. The fascial boundaries contain the blood, meaning the overall volume is physically restricted.
But below the arcuate line, that's where the danger really scales up, right? Because the posterior rectus sheath effectively disappears down there.
That's exactly it.
It leaves only the transversalis fascia separating the muscle from the peritoneum.
Which means a bleed from the inferior epigastric artery has virtually zero anatomical resistance.
It just flows.
Right. The blood can dissect inferiorly right into the prevesical space, the space of Retzius. Or it can cross the midline, and that creates this massive bilateral pelvic hematoma.
Oh, wow. So they can bleed out internally.
Absolutely. A patient can lose a lethal volume of blood into that retroperitoneal space before the skin ever shows even a hint of ecchymosis.
That's terrifying. Which brings us straight to the imaging. If the physical exam is unreliable, and, ultrasound is often operator dependent, plus it misses the active arterial component, we really have to rely on the contrast-enhanced CT.
Yeah, the contrast CT is the absolute gold standard here. I mean, there's no substitute because it maps the entire physiological battlefield.
Right, because a non-contrast scan just shows you a mass.
Exactly. You just see a lump. but the contrast phase tells you the precise volume of the hematoma, the anatomical spread, and most critically, it highlights active contrast extravasation.
Blush.
Right, it tells you definitively if there is an ongoing arterial bleed.
And finding that active extravasation on the scan, I mean, that forces a complete paradigm shift. As a surgeon, your management of RSH is guided entirely by the patient's physiology, right? Not the anatomical label of the disease.
That is the key takeaway. You are treating the hemodynamic state, period.
Right.
Because a stable patient with a massive bilateral RSH is treated vastly differently than an unstable patient with a moderate one.
The size of the bleed doesn't dictate the intervention?
No, not on its own. The presence of blood in the abdominal wall is totally secondary to what that blood loss is actually doing to the patient's end organ perfusion.
Which really brings up the primary psychological friction of treating RSH, I think, because muscle memory for a surgeon is incredibly powerful.
Oh, it's hard to fight.
Right. You see a pool of blood, your training dictates that you open the abdomen, wash it out, and tie off the vessel. But the literature insists that doing nothing mechanically is actually the most aggressive and successful first move.
Yeah, we really have to keep the scalpel on the tray.
But let me push back on that for a second. If a patient is actively bleeding into a confined space, isn't quote-unquote watching and waiting, basically just letting a bomb tick, I mean, how do we trust that observation alone is actually safe?
Well, holding back feels totally counterintuitive, I'll give you that.
Yeah.
But conservative care is the definitive first-line treatment here. And to be clear, when we say conservative, that does not mean passive observation.
You're not just staring at them.
Exactly. We are essentially weaponizing the patient's own anatomy.
Oh, I like that. Weaponizing the anatomy.
Right. So the goal is to utilize those fascial boundaries we talked about as a natural pressure dressing. As the hematoma expands, it meets the resistance of the intact fascia.
Okay, so it builds up pressure.
Yeah, the pressure inside that closed space rises until it literally overcomes the mean arterial pressure of the bleeding vessel.
Wow.
And that creates an internal tamponade that effectively halts the bleed.
Okay, so to make that tamponade successful, we really have to manipulate the patient's systemic physiology. We can't just let them lay there writhing in pain.
No, definitely not.
Right, so we are looking at rigorous analgesia because pain drives up the sympathetic tone, which drives up the blood pressure.
And if the blood pressure spikes,
it subsequently blows out any fragile clot that's trying to form.
Exactly. It's a vicious cycle. So alongside the analgesia, we are also instituting strict bed rest. We have to prevent any further shearing forces from the rectus muscle contracting.
So no moving around.
Right. And while they're resting, you are monitoring serial lactates, you're tracking pulse pressure variation, and you are closely watching the hourly urine output.
To make sure the kidneys are getting perfused.
Exactly. You're gauging whether that internal blood loss is compromising end organ perfusion.
And then there's reversing the coagulopathy, which is where this management gets highly, highly active. I mean, a massive portion of these patients are going to be on some form of systemic anticoagulation.
Oh, the vast majority of them, yes.
And the protocols diverge significantly depending on the agent, right? Like if they're on a heparin drip, we're obviously pushing protamine.
Right, that's standard.
And if it's warfarin, we are going down the standard route of prothrombin complex, concentrate PCC, and vitamin K to rapidly replenish those clotting factors.
But the DOACs, the direct oral anticoagulants, that is where you see the most hesitation and variability in the ER right now.
Why is that? Just lack of familiarity.
Partly, yeah, but also simply because the reversal agents for DOACs are newer, and they are often very tightly restricted by hospital pharmacies.
Ah, right, the red tape. But with the DOACs, if supportive care and just holding the dose isn't enough, we are reaching for those specific reversal agents.
Yes, like edartizumab for dabigatran.
Right, and andexanet alpha for your factor-getting inhibitors like rivaroxaban and apixaban.
Exactly. And the objective across the board, no matter the drug, is to abruptly halt that biochemical disadvantage so the physical tamponade can actually hold.
And while you're reversing the coagulopathy, you are heavily scrutinizing those hemoglobin trends. But the transfusion thresholds here shouldn't just be arbitrary numbers, right?
No. Definitely not. You are transfusing for symptomatic anemia or clear evidence of end organ hypoxia.
You're not just chasing a number.
Right. Because the body will eventually resorb the trapped flood over weeks or even months, assuming, of course, that you can stabilize the initial leak.
Okay, so that strategy makes perfect sense for a stable patient. But we need to talk about the failure rate, because conservative management is the gold standard right up until the exact moment the patient falls off a cliff.
Yeah, and missing that window to escalate is disastrous.
Completely. So how do we spot the failure?
Well, you have to watch the trend lines, not just isolated data points. Escalation is mandatory the moment the clinical picture deteriorates despite your active resuscitation.
So like the numbers keep dropping even with fluids in blood.
Right. A rising lactate, persistent tachycardia, or a steady downward slide in hemoglobin, despite adequate transfusions. All of that means the internal tamponade has failed.
And at the bedside, I imagine that looks like pain breaking through your multimodal analgesia or even just a physically expanding abdominal girth.
Absolutely. You can literally see the abdomen getting larger.
But the sources also highlight a very specific predictive combination on that initial CT scan that should put you on high alert from minute one, right?
Yes, this is crucial. A large initial hematoma volume combined with active contrast extravasation is a massive red flag.
So if you see that blush,
If you see that contrast blush on the scan, the statistical likelihood that conservative measures will fail just skyrockets. You need to be anticipating the next intervention before that patient even rolls out of the CT scanner.
and historically, that next intervention was always a laparotomy, but the modern pathway relies heavily on endovascular damage control. We are talking about selective angioembolization.
Yeah, interventional radiology has completely revolutionized the mortality rates of RSH. It really has.
It's the ultimate intermediate step.
Exactly. If the patient is actively bleeding, but they're still hemodynamically stable enough to actually survive the transfer down to the IR suite, angioembolization is your definitive next move.
It really is a brilliant tactical advantage because, it's like sending a microscopic plumber through the pipes to plug a leak from the inside. You are securing the bleeding vessel from the inside out, completely bypassing the hostile environment of a shredded coagulopathic rectus muscle.
That's a great way to put it. The interventional radiologist threads a catheter, performs the angiogram to map out the exact collateral flow, and then they selectively deploy microcoils or gel foam directly into that bleeding branch of the inferior or superior epigastric artery.
Let's focus for a second on why avoiding the OR is so vital for this specific demographic, because we are often dealing with frail, elderly patients who are fully anticoagulated and loaded with cardiopulmonary comorbidities.
Right. And a laparotomy is a massive physiological hit for anyone, let alone an 85-year-old.
That's devastating.
Exactly. Slicing open the abdomen of an 85-year-old on apixaban triggers a profound systemic inflammatory response. I mean, the anesthesia alone can cause severe vasodilation that just tanks their already precarious blood pressure.
It's a recipe for disaster.
It really is. IR avoids that secondary trauma entirely.
Yeah.
You achieve hemostasis without breaching the peritoneum or subjecting them to the physiological shock of open surgery.
But, IR is not a magic bullet.
No, unfortunately not.
Sometimes the interventional suite is booked, or the facility just doesn't have an interventional radiologist on call at 3 a.m.
Or the IR team gets in there, but extreme vasospasm or tortuous anatomy prevents them from actually cannulating the vessel.
Right. So when that endovascular route fails, or the patient is crashing way too fast to even transfer to IR, we finally have to push through those double doors into the OR.
Yeah. And to be clear, surgery is strictly the last line of defense in the modern era. It is reserved exclusively for when you are totally out of options.
So the sources outline very specific indications for when a surgeon absolutely must intervene. Persistent hemodynamic collapse despite massive transfusion is the obvious one, right?
Right. If they're bleeding out faster than you can pour blood in.
Exactly. We also have to operate if the hematoma becomes infected and turns into a massive abdominal wall abscess.
Yeah, you have to drain that.
Or if there is lingering diagnostic uncertainty, like say the patient is deteriorating and you just cannot definitively rule out an underlying ischemic bowel hiding behind that hematoma.
But the most insidious indication, honestly, is abdominal compartment syndrome, or ACS.
Oh, ACS! This is where the sheer volume of the bleed starts acting like its own secondary pathology.
Exactly. The intra-abdominal pressure rises so high from the hematoma that it physically begins crushing the inferior vena cava.
Which decreases venous return to the heart.
Right, the cardiac output drops. And it compresses the renal veins, which shuts down the kidneys, and it pushes the diaphragm upward, causing the peak airway pressures on the ventilator to just absolutely skyrocket.
It's a total systems failure.
It is. And when you see ACS developing, you are forced to perform a decompressive laparotomy just to relieve that pressure, almost regardless of the bleeding risk.
So let's put ourselves in the operative field for a minute, because this is the absolute last resort. Does that mean the surgical field and the patient's physiological state make this a uniquely dangerous operating environment?
Oh, without question. By the time you resort to surgery, the patient has already declared themselves a failure of both conservative management and likely IR.
So they're in bad shape.
They're in terrible shape. They are deep into the trauma triad of death. They are profoundly acidotic. They are hypothermic from massive internal blood loss, and their coagulation cascade is just completely depleted.
So the surgeon's primary goal isn't necessarily a perfect repair, it's just damage control.
Exactly. Damage control is the name of the game.
They evacuate that massive clot burden, which instantly relieves the compartment pressure, but then comes the really hard part, finding the actual bleeding source.
And finding a severed epigastric artery in this environment is an absolute nightmare.
Because it retracts, right?
Right. When these vessels rupture, they immediately spasm and retract deep into the muscle belly. Plus, the hematoma itself essentially macerates the surrounding rectus muscle.
The tissue just turns to mush.
Exactly. The tissue becomes incredibly friable and necrotic. Trying to find a retracted, actively bleeding vessel in a shredded muscle bed, it's like trying to find a bleeding red thread in a bowl of ground beef.
Wow. What a visual. Which is exactly why attempting to precisely ligate the vessel often just fails. The tissues just tear when you try to put a stitch or surgical clip on them.
They just fall apart in your hands. So when direct ligation is impossible due to that tissue destruction or severe coagulopathy, the surgeon has to fall back on temporary packing.
Like literally packing it with sponges.
Yes. They tightly pack the rectus sheath with surgical sponges to create an artificial mechanical tamponade. They will often just leave the fascia open, apply a temporary negative pressure dressing, and transfer the patient directly to the ICU.
So they don't even close them up.
No, you can't. You transfer them to correct the acidosis and the coagulopathy with a planned relook operation 24 to 48 hours later.
And the complications that follow this kind of salvage surgery are just brutal. I mean, the literature heavily emphasizes the risk of myonecrosis.
Yeah, myonecrosis is a huge problem. And it's a direct result of the local pressure dynamics. The hematoma acts like a localized compartment syndrome within the rectus sheath itself.
So it's choking the muscle.
Exactly. It strangulates the capillary beds that feed the muscle fibers. The muscle tissue literally dies, which severely compromises the abdominal wall integrity and creates this massive, massive risk for surgical site infections.
And you also have high rates of skin necrosis over the incision site, right? Because the subcutaneous blood supply has been sheared off by the swelling.
Right.
Plus, there's always the overarching threat of the patient just rebleeding once their blood pressure finally normalizes in the ICU.
It is a grueling post-operative course,
Mm.
which frankly underscores exactly why we go to such incredible lengths to manage this non-operatively in the first place.
Right. So let's pull all of this together. The stepwise management of rectus sheath haematoma requires you to completely override that instinct to immediately operate on a bleed. It demands a deep understanding of abdominal wall anatomy, coagulation cascades, and the profound physiological toll of surgical interventions.
And, navigating that acute phase is a massive victory in itself. But there is a really provocative secondary challenge that emerges once the patient is finally stabilized on the ward.
Right, the aftermath.
Yeah, the bleeding is stopped, the hemoglobin is stable, but now you face the thrombotic risk assessment.
Well, of course, because the patient was on anticoagulants for a reason to begin with.
Exactly.
They might have a mechanical heart valve or severe atrial fibrillation or a history of massive pulmonary embolisms. We chemically force their blood to clot to save their life from the hematoma, but now they are basically a ticking time bomb for a catastrophic stroke or a PE.
And restarting anticoagulation after a massive hemorrhage requires navigating an incredibly precarious tightrope. You have to step back and ask why the bleed occurred.
Was the dosage wrong, or was it purely mechanical trauma from the cough?
Exactly. And figuring that out requires a serious multidisciplinary discussion between surgery, cardiology, and hematology. You are reviewing all their medications, adjusting dosages, or maybe utilizing bridging strategies with shorter-acting agents.
So the acute hemorrhagic emergency ends, but the strategic management of their underlying thrombotic risk is really just beginning.
It's the ultimate balancing act. You're trying to protect them from a fatal clot without blowing out the fragile hemostasis that you literally just spent days fighting to achieve.
It's fascinating and terrifying all at once. Well, that wraps up our deep dive into the management of rectus sheath haematoma. If you found this breakdown valuable, we have a quick favor to ask you. Please take a second and share this with at least one colleague or friend in the medical field.
It really does make a huge difference for us.
It really helps us spread the word and keep bringing you these deep dives. Also, definitely check out our YouTube and other social media pages for more content. And if you haven't already, do check out our previous season and episodes. We have covered some very relevant clinical topics that tie directly into the physiological principles we discussed today.
Lots of good stuff in the archives.
Absolutely. Thank you for joining us. The next time you are on call and that acute abdomen rolls through the door, just take a beat. Look closely at the clinical picture. The clear target you are looking for might just be a chameleon waiting to bait you. See you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.